Welcome to Our Scars Speak. My name is Christina Miner. I'm the host of this podcast. And before we begin, I want to give a disclaimer that even though we are operating as professionals, we are not being held liable for anything that is discussed here today. We are merely just given information, given some education so that everyone can learn a little bit, but we are not being held liable. And at the same time, we encourage everyone to follow their own medical treatment by their own physicians and medical team and even mental health team. So without further ado, today I'm so excited about welcoming Dr. Priti, I think I pronounced, or I probably did that wrong, Priti Shah, or Shaw, okay. I got part right, which I'll let her share her name and who she is. And I met her actually during an interview with Reba Hollingsworth, and she was just so inviting. And I know some people who contacted me, their experiences weren't always like that with a radiologist, but I must say she has been absolutely such a blessing far as just being informative and just being an open, nice, caring doctor. And so without further ado, thank you so much for coming on Our Scars Speak.
Thank you so much for having me, and thank you so much for the kind words. I have to say that when I heard from you about maybe participating in the podcast, I was a little starstruck because having met you with that interview and hearing your story, and then seeing that you wanted me to kind of be a part of that was very humbling. So I'm very appreciative and grateful for the opportunity.
Oh, thank you. I appreciate it. So I want you to make for sure you pronounce your name correctly for us, because I just totally messed it up, even though I tried to practice beforehand. But definitely share your name and then also share a little bit about yourself. Not the doctor aspect so much, but just about you. How do you describe you?
Okay, well, you did fine. It's Priti Shah. And I was born and raised in Baltimore. We'll start there.
Okay.
We're just outside the city. I have two older sisters and my parents who still live in Baltimore. And even though I've been in Richmond, Virginia for about 15 years now, I still consider Baltimore home in a sense, because that's where my parents are and my immediate family. But yeah, just growing up, I had a great childhood. I went to college in Baltimore. I went to undergraduate school in Baltimore, medical school in Baltimore. I thought I would never leave Baltimore and my family. I did 1 year abroad to just kind of test the waters as a college student, and then decided I wanted to come back home and stay in Baltimore. I did a 4-year radiology residency in University of Maryland in Baltimore, and I came to Richmond, Virginia for last year of training, of subspecialty training in women's imaging. And I was supposed to go back and go back to my family, and things just fell into place. And it's been 15 years now that I've been here at Virginia Commonwealth University Health here in Richmond, Virginia. So it's just the place has grown on me, the program and everything. So I'm really fortunate to be here. I'm also a mom, so that's what most of my free time goes to. You'd asked about hobbies. I like to swim and read and jog and travel, but now most of my time, any free time, is spent with the children and the husband. I have 5-year-old twin girls who are a total joy, but a lot of work, but a lot of joy, more joy. And honestly, I can't picture life without them. So they've just been one of the greatest blessings and joys in our life. So that's kind of where I spend my free time.
That's beautiful. Yeah, I remember you saying you had twins, and I was like, "Woo, they're 5." That's that's
it's a whole nother level of sass when they're 5. Yeah.
Oh my goodness. So we know that you've had all this medical training and gone to school all these years, but what led you into this part of just to become a doctor, and especially in radiology? What led you here?
Growing up, I always liked science. I always liked biology. At some point, my dad got a coffee table book, and it was something called The Incredible Machine about the human body. I think it was National Geographic or Discovery or something educational. And just browsing through that, I really got interested in just the body. And I was
Wow.
fascinated by all things human, from this is a kidney and this is, what it does, to this is how the cells do what they do to keep you healthy and keep everything balanced and in order. It was just such an amazing, intricate kind of machine. It is what I feel like we are as humans. And so I went to medical school. And I will be honest that when I went to medical school, I had no idea what a radiologist was or what they did. But we were fortunate to have some radiology faculty come in on our anatomy labs and teach anatomy as it appears on imaging, like X-rays and CT scans, and really correlate it with the actual human anatomy in real life. And so that was eye-opening. And I had the good fortune of having a really good mentor who was one of the professors that came in. He was a neuroradiologist. And he was just so exciting and engaging and smart. I took to him and shadowed him in his work later on. And that's when I kind of learned what a radiologist does. He reads and interprets images that make findings to diagnose diseases, cancers and not cancers, that explain symptoms, explain things that are going wrong with patients. And that discovery allows them to get treated and taken care of. So I saw this amazing role that he had in taking care of a patient, even though, he may have been behind the scenes. He was a neurointerventional radiologist. So he did a lot of procedures involving the brain and the spine, which was a little too intense for me. But it gave me the opportunity when I shadowed him to see that he also had a lot of patient interaction in what he did. So doing procedures, he had follow-up clinics, and, as smart as he was and good at what he did with imaging, he was equally as charismatic and enthusiastic with his patients. And so I just saw kind of that spark that, hey, this is what a doctor can be. They can kind of look at the body, visualize, this amazing human body and the anatomy, and put it together with the real person and take care of them. So that inspired me to pursue radiology. And then as a radiology resident, we rotate through all the different subspecialties of the field. So like neuroradiology, chest, bone, brain, all of those things. And I, on my breast imaging rotation, again, had no idea what breast imaging was, that it was a thing, but I had, again, the amazing fortune of a really great mentor. And I just liked how she did what she did. She was also very smart, very matter of fact. And I saw that she interacted a lot with patients and wasn't just doing the procedures, but she did a lot of education, a lot of reassurance. And I just sort of found my niche there. And the way that she was teaching resonated with the textbook that I was using at the time, which is written by one of the kind of legends in our field. And when I mentioned that to her, she said, well, yeah, because Dr. Cardonosa, who read that book, we trained together. So yeah, we are like-minded.
Wow.
I found out that Dr. Cardonosa was just 3 hours away at Virginia Commonwealth University. And so I thought, wow, she's so close to me in Baltimore. I have got to go there and do my fellowship with her. I've got to learn breast imaging from, literally the person that wrote the book. And that was in 2008. And I just fell in love with how she practiced, how she took care of patients, really very patient-centered, very patient hands-on. And I wanted to be a part of that. And so 15 years later, here I am.
Yes, I have to actually say, you are just so personable, because I've worked in the medical field. First and foremost, my hat goes off to you, because I used to, when I worked in the medical field, sometimes I would stay back with my patients while they were getting testing done, and I would look, especially neuro, at the brain, and the radiologist was trying to explain it, but I'm like, I don't know what I'm looking at. It's so mesmerized, and they were like, look, there's that and there, and I was like, what is that? It was just like a blob of just mass. So my hat goes off to you, because you are very, very smart, because it's a lot to look at. But yeah, I have to say you're very, very personable. And that was one of the things that really, when I was like, man, I need a radiologist. And then I met you and I was like, wow, I was like, she hopefully will say yes, because you had that personal aspect. And I think sometimes people in all professions can get lost in the profession and in the work, that they forget about the actual mental health side and
Yes.
as far as the personable side of the to be able to treat someone. So thank you so much for that, because it shows on camera, I'm sure, but also off camera, how I've met you. So that means a lot to a patient. So so this basically was just you falling in love with medicine and then radiology. So you didn't have like a personal experience as far as when it came to breast cancer, as far as family or anything like that. It was just, you felt this was your passion.
I did. And kind of like what you were saying, that, when I saw that radiologists can be so personable and caring, it just reminded me of why I went to medical school. I think it was, at a time in my training where I was behind a computer a lot, interpreting images, which is what a lot of us do all the time. Most patients don't meet their radiologist.
Absolutely.
But when I had this rotation and I got out of the reading room and I was seeing patients and talking to them with my attending with my mentors, it just kind of brought me back to, this is the perfect marriage of the anatomy, the clinical care, the relationships, and it all fell into place.
I love it. I love it. I guess because I'm a personable person, so anybody's personal, I love it. Yeah, because I hear so many people saying, I never met my radiologist. And I'm like, well, you kind of got to think of it. Sometimes you won't, in some situations, sometimes you will. I think it kind of depends. I don't know how really that goes, but I just know when I had my testing done, they definitely came in, and I knew when they got the radiologist, this probably is not a good sign for me.
Yeah, what we don't, often talk about too is that, the radiologist is, even not in breast, they are still part of your care team. They're
Absolutely
still collaborating with your doctors behind the scenes, to kind of help in terms of understanding the diagnosis, making recommendations on, what to do next. And so that really gives us the opportunity to be an indirect part of patient care. And I've always been a sort of behind the scenes person. In college and high school, I was in theater, but I like to be doing the AV crew, the lights, the sound. So I will put other people in the spotlight, but I enjoy that sort of detective work, and behind the scenes. And a lot of radiologists are very connected to their referring physicians behind the scenes. And that's kind of how we do patient care when we're not patient facing per se.
Absolutely. And I always tell people to try to think about like your pathologist. You don't ever see the pathologist. So you hear the doctor interpret what the pathologist found. And so it can be, because a lot of people, they question that. And I'm like, well, you might not. And it's not a bad thing. It's just how that's usually, some of them may not come out to talk to you. But I always tell everybody they are doctors too. And what they say matters. And I know I had an issue with the cyst, and my doctor was saying one thing, the radiologist was saying another. I said, okay, guess what? We're going to get a pathologist involved. It's like break it. But so yeah, I totally respect the profession 100%. With that being said, with breast cancer and breast health altogether, breast tissue period, I kind of would like to hear a little bit, because we know that some changes have been made, which you can definitely elaborate on that if you like. I did have a question though for you, which kind of probably bring us into what you're getting ready to discuss, because I know you have a presentation. But I had someone to say, well, why do they do mammograms when ultrasounds can show more? And I know you're going to go over that, but I also know that recently regulations changed that if a person does have a certain amount of density, that they can now ask to get an ultrasound done because of the density, if it's heterogeneous, or which you'll go over all that or more. But can you explain? I guess we could just start with explaining what has been changed and why. But I do want people to understand that even though this has been changed, insurance plays a big part. So your doctors may say, yeah, they need this, but the insurance may say, no, they don't. So that you may have to go back and talk to your doctor about coding. I want to throw that out there to people who are listening. But could you explain what exactly has happened with the regulation as far as the dense tissue?
Sure. So back in March, the FDA announced a regulation that will require all radiology practices in all states to inform patients of their breast density in plain language. And some states already do that. Virginia is one of them. Over 30 states have state legislation mandating notification about breast density. But it's a little bit of a patchwork because the language, the verbiage itself is not standardized. There's still a lot of questions about what it means and what to do about it. So as of September of 2024 is when this goes into effect. All facilities will be required to use very specific words. That's a verbatim. They have to use the language that they specify to tell patients if they have dense breast tissue and if they don't have dense breast tissue, which I think is a great step because, as we'll see, some of the words, the wording and the descriptions are a little bit confusing. And so to be able to tell patients they don't have dense breast tissue is also very reassuring. The legislation will also require that the statement about that includes the fact that dense breast tissue is normal. It is not necessarily cancerous, but it can increase your risk for breast cancer. And it will also need to include a statement recommending that a patient talk to their provider about their specific risk, their specific situation to determine what is best for them in terms of supplemental screening. And the American College of Radiology just released some new updated guidelines for dense breast tissue and for screening in high-risk women. And they do mention breast MRI as sort of the supplemental screening of choice. To just address the question about why not starting with ultrasound. It's a great question, and we get that a lot. Ultrasound is still best at finding small lumps that can be hidden under dense breast tissue, but mammograms are the gold standard for detecting early stage breast cancer, which is what we're always trying to catch with screening. There's about a 40% reduction in deaths from breast cancer, proven over 40 some years of follow-up in many trials across the world, that when screening is done yearly in women starting at age 40, it has the best benefit for survival through early detection. So ultrasounds, MRIs are great supplements for patients with dense tissue, but they don't necessarily capture that very early stage disease that is the most treatable with the best outcome.
Oh, okay. And you were saying that, so basically they've made it very simplistic far as the wording for people to understand, because I know, because density, and I'll let you explain, because I was told heterogeneously, and I was like, well, what is that? Like, I had no clue what it was. And I like the fact that you did tell us that it is normal, but I guess it's just certain degrees of it. So feel free if you want to go ahead and explain, because I know you have a presentation.
It's not so much a presentation as just a visual aid. Again, visual anatomy, as a radiologist, I feel that a picture is worth 1,000 words. And often in the clinic as well, sitting down with a patient and reviewing their images really hits home. And to be able to describe, a lump or a mass, dense versus not dense, when they see the image, we see kind of an aha moment and it all comes together. So that's why I just wanted to share some examples and how that fits together. So I'm going to share my screen here.
Can you still share it? I think so.
Yes.
Okay. Yep.
And I promise there will not be a quiz later.
And for anyone watching on podcast, you can definitely see this on YouTube or our Facebook page. I'm gonna see if I can add the pictures maybe in the podcast at the bottom. I'm not for sure if I can, but if not, feel free to go to YouTube or Facebook.
Okay, great. So this is a mammogram, or half of a mammogram, I should say. These are the side-to-side pictures that are taken when a woman has a mammogram. And we look at them sort of hanging back to back. So just for kind of orientation of anatomy, this is the pec major muscle, the pectoralis major, that's normal to see. It's very kind of bright white. These little balls here are completely normal lymph nodes that are part of our immune system. They live in our armpits, men and women. They actually live all over our bodies, and we often capture them on a normal mammogram. And so we're looking here at the front of the breast. We kind of see the nipple here and all the way to the back of the breast. Now, before we talk about fatty and dense, just to explain some of the composition of breast tissue. Breast tissue is made up of 3 different types of tissue in all women and in varying amounts. There's fatty tissue, which we all have everywhere, of course. There's also the glandular tissue, which is what comes in at puberty. And when we are pregnant, that's what swells. That's what makes the milk when we're breastfeeding. That tissue is with us our entire lives, even when we're not pregnant, even if we're not breastfeeding, even after menopause. The glandular tissue and the fatty tissue is all supported by fibrous tissue, kind of scaffolding or connective tissue that keeps everything together. And on X-ray, on mammograms, fatty tissue is this gray tissue here. It is translucent. You can see through it. For example, we can see some of these lines here, which are blood vessels. And I like to use the analogy that fatty tissue is kind of like Scotch tape, or thinking about it differently, it's like a clear blue sky. You can see the birds, you can see the airplanes through the clear blue sky. Fibro and glandular tissue is what makes up the whiter densities or the whiter coloration on mammograms. So this is an example of a person that has mostly fatty tissue, and this patient has dense breast tissue. So dense breast tissue is the patient that has more of the fibrous and the glandular tissue in proportion to the fatty tissue. And in this patient, we see the fatty tissue kind of up here in their chest wall against their pec muscles is gray. We can see through it. But all of this white tissue here is their fibroglandular tissue. And that's just how they're made. It's genetic, it's hormonal. It does not go away with menopause. This patient is actually 88 years old. And so it's just sometimes even symmetric or asymmetric, I should say, from side to side. It's just how the breast tissue is made. So dense breast tissue can pose a problem because small lumps or masses can hide in the dense tissue. The dense tissue also can serve as a risk factor for breast cancer. So I'll show some examples, but one thing I did want to point out on this patient with dense breast tissue is that she has these white blobs that are kind of light bulb bright scattered in both breasts. And some of these are little lines and some of them are shaped like popcorn. Some of these are round. These are calcium deposits or calcifications. In this patient, these are all benign. Calcium deposits form most commonly from benign hormonal fibrocystic changes, getting older changes, and we see them very commonly. Sometimes, though, they can be the earliest signs of breast cancer, and we'll kind of talk about that in a little bit. But one thing I wanted to point out is that the reason that mammograms work, why they're so effective at early detection and improving survival, is that no matter how dense this breast tissue is, how much like masking tape it is, or a cloudy sky where we can't see the birds and we can't see the airplanes through it, these calcium deposits are always going to be brighter white than any dense breast tissue, even muscle here. So even though this patient has lots of tissue that's hard to see through, these calcium deposits light up kind of like light bulbs on the mammogram. So we can see them. And as sometimes, not these calcifications, but sometimes calcium deposits can be associated with early breast cancer, that is how we detect it. And these calcium deposits we don't typically see on ultrasounds and MRIs, CT scans. The technique of a mammogram, the resolution, the dose, all of that is very specific to breast tissue and allows us to pick up these teeny tiny dots, which these are what we call large, but I'll show some of the examples that we look at for breast cancer diagnosis are on the order of a fraction of a millimeter in size. So this is just that dense breast tissue. And of course, there's a spectrum. So I showed you the extremes. This patient has mostly fatty tissue on the left. This patient has mostly dense tissue all the way on the right. And of course, there's a gray area, no pun intended or pun intended, of what's in between. And so when we as radiologists assess the breast tissue and assign a density category to it, we can think of it in quartiles. So this patient all the way on the left has less than 25% of her tissue as that white, dense fibroglandular tissue. So we label this as almost entirely fatty. This patient has 25 to 50% of her tissue that is the white fibroglandular tissue. So that is labeled scattered fibroglandular densities, which can be very confusing because it has the word density in it.
Right.
And so these two categories here, the fatty and the scattered, are not dense. And so this is why I really like this part of the new FDA regulation, is that we would be required to have a separate statement saying that you do not have dense breast tissue, even though the parenchyma, the breast tissue, is labeled scattered fibroglandular densities. That literally just means it's kind of splattered and scattered around your breast. It's not impeding the detection of a mass or a lump.
Okay.
And then these two categories here are what's considered dense. When we say you have dense breast tissue, it's over 50% of the breast tissue, and that's further divided into 50 to 75%, which is labeled heterogeneously dense, and then extremely dense, which is 75 to 100% dense breast tissue. So these two categories are the patients for whom that statement will apply, that you have dense breast tissue. You may want to consider supplemental screening based on your individual situation. And about 50%, 40 to 50% of women have dense breast tissue. So that applies to them. The problem with dense breast tissue, of course, we talked about, is masking or hiding small lumps.
Right.
So just to kind of step back a little bit and talk about what is a lump and what is a mass. Masses and lumps are like beads. They're like little marbles in the breast. They hold space in 3 dimensions, like a little ball. And the reason that we can see them on really any imaging, X-ray, MRI, ultrasound, is that there's contrast. They are a different shade of gray or white than the surrounding breast tissue. So when we talk about a patient with mostly fatty breast tissue, most of her tissue is this gray, translucent, Scotch tape, clear blue sky. And we can see, when I've circled it in pink here, this ball. And I show both images here. This is that side to side view, and this is the top to bottom view, because lumps or masses are 3-dimensional. So whatever angle that we image the breast, we can see it. So sometimes the technologist may do extra pictures, turning the X-ray tube, turning the patient, shifting the breast, but the lump doesn't go away because it takes up space. And it's pretty easy to see because it's surrounded by gray tissue. So we can see the white lump. So in patients with fatty breast tissue, it's easier to see lumps or masses. But as the tissue gets denser and we add more of that overlapping fibroglandular tissue, it's harder and harder to perceive these masses. Even though they hold space, they're the same shade of gray as normal background breast tissue. And so they're hidden. So in this patient, we can see it surrounded by fatty tissue. This patient has some of that scattered tissue, so we kind of lose the edges. This patient, we kind of have to squint because it's hidden with some of her dense tissue. That little triangle was a sticker. She actually was feeling the lump, so that draws our attention to it. But we can still make out this kind of pushing out border, something maybe expanding like a water balloon. And then this patient, she's extremely dense. Her breast tissue is extremely dense. And she was feeling a lump that we don't really perceive on this mammogram. And this patient had about a 3-centimeter breast cancer. And so this is why the statement will mention that the sensitivity of mammography is decreased with dense breast tissue, meaning that it's harder for us to detect small lumps in the setting of this cancer because they can, or in the setting of this dense tissue, excuse me, because they can hide. But then going back to the calcium deposits, just a little lesson on the anatomy of a milk duct. Again, I love anatomy here. In our breast tissue, the milk ducts are the ones that transport the milk to the nipple when we're breastfeeding. But again, we always have them, even if we're not pregnant, if we're not breastfeeding. And the milk duct is this part here, and it's connected to what are called lobules, which are the glands that actually make the milk. And then the fluid, the milk, is kind of travels to the duct for when we feed our babies. But even when we're not breastfeeding, we have all of this tissue. And so the ducts and lobules are just there for life. And that's where the cancers can form. The majority of breast cancers form in those tubes or tunnels of the milk ducts. And so we start to see these cells crowding the milk duct, and they're cancer cells. Their growth is just all over the place. They don't regulate it. They outgrow their blood supply, outgrow the nutrients, and they start to die off and slough. And all of that is stuck in the milk duct because it hasn't invaded the surrounding tissue to form a lump. So when that tissue or when those cells die, they calcify. And the calcium deposits, because they're stuck in the milk duct, we can see them on X-ray. Again, they are brighter than even the densest breast tissue. So separate from a lump, these calcium deposits really stand out. So this is a patient with DCIS, ductal carcinoma in situ, different than the benign calcium deposits that we saw in the first patient. These are kind of in little lines and dots and dashes. You can see that they're kind of making out the form of a branching milk duct because they're forming amidst the cancer cells in the milk duct. And even against muscle, which is really bright white, we can still see these calcium deposits overlaid. So this is why mammography is the gold standard in terms of detection of early breast cancer, because it can routinely detect stage 0 or ductal carcinomas in situ before they've grown to form a lump, before they're feelable or palpable, and by definition, before they've spread to lymph nodes. And these calcium deposits cannot be detected with ultrasound or MRI or CT. It's just mammography that can see them.
Yeah, that's what I had. I had the DCIS, and I've heard some people say, well, DCIS is not cancer. I was like, no, it's cancer. It's just it hasn't gone outside of, it's not invasive. It hasn't gone outside of the ducts. But it was interesting because the second time they found it, I found it in 2015. The same pattern was in 2019, and they were going to give me 6 months to come back to make for sure the lump that they seen hadn't changed, because the calcifications, they said, didn't necessarily look like the pattern, I guess, that, and I told them no. I was like, you're going to come in, you're going to see me in like 2 to 3 months, because I'm not waiting 6 months. And thank goodness I did, because a lot of my ducts was just full with cancer. So yeah, that is something. I have a question. You stated that far as the breast cancer, we know that a lot of times because of imaging, we find out the early detection. And we know that because the dense tissue, excuse me, my throat, dense tissue can hide. What are some of the other reasons why they say that there's a correlation between breast cancer and having dense tissue? Is there another reason outside of just not being able to possibly see that there's something hiding?
That's a great question, and there's not a definite answer for that yet. So that mechanism is still not unlocked, I guess. Yeah, I could say. There's some theories that dense breast tissue makes a growth factor, makes something that causes proliferation of cells and cancer, but it's not 100% sure, and it's not 100% consistent. The important thing to note, though, is that even though dense breast tissue can increase a woman's risk for breast cancer over her lifetime, it doesn't increase the risk to the point where she is considered high risk. Here that the average risk for breast cancer is 12.5% in their lifetime. And that comes from that statistic that we always hear: 1 in 8 women will be diagnosed with breast cancer. But to be labeled as high risk, that is a different calculation, basically, that will assess the patient's risk as over 20% of a lifetime risk for breast cancer. And so dense tissue does increase that from 12.5% up, but it is a constellation of factors that may increase their risk further to be bumped up to that high risk category. And so that's why we have patients talk with their doctors to see what else they may be in terms of risk factors that would elevate their lifetime risk to a point where they would need additional screening, but also maybe some preventative measures and risk reduction. So it's kind of one in many things that can increase the risk for breast cancer.
Okay. Yeah, that's good to know. And also, because I remember when I first heard density and fat tissue, and I think a lot of people, even probably now who are listening, who aren't that familiar, I was like, oh my God, okay, I know I need to lose weight, because I thought automatically like it has something to do with the size of the breast or something.
No.
And without that explanation, like you just did so beautifully, I had no clue, because they just threw the words out there. And I was like, okay, maybe my breasts are too large. And that's when I had asked my doctor, and he's like, no, you can have small breasts and still have dense breasts. So thank you for going over that. That was very good, because I know a lot of people probably have been very confused, especially about the calcifications, because I know that some can be benign. And like you said, some may be actually malignant. And I like the way that you even showed the picture of how it was scattered. And then some were like in a particular pattern of the duct. That was interesting to see. Now, something that's on a lot of our imaging reports, because imaging reports can be a little intimidating, because sometimes we don't know what all the lingo is. And I would love if you could do a whole entire study on that presentation for us, but to kind of keep it kind of simplistic for us. I know a lot of us are familiar with tumors, and density is a big thing right now, but the BIRADS, I seen that. I researched it, like I told you privately, and freaked out, because I'm like, oh my God, I'm a 4, I think it was B. I was just like, what does this mean? And then I started looking more, and of course Google will scare you like crazy. And I hadn't had I had a biopsy yet? I don't think I had a biopsy yet. So I seen that score, and I didn't know. And I was just researching every little thing on the radiology report. Could you go over that with us? What that means?
Yeah, absolutely. So BIRADS, it stands for Breast Imaging Reporting and Data System. And it is many things for breast imaging. It is basically a quality assurance system for all of breast imaging, and especially mammography, from everything from image quality to terminology of descriptors of things that we see on the mammograms. For example, these calcium deposits that we showed, some are clearly benign and some are very highly suspicious for cancer. The reason that we know that is because they check certain boxes in terms of their shape, their distribution, where they are in the breast, how bright white or kind of vague they are. So we use lots of terminology that has a specific glossary and that we're supposed to use. And so that the BIRADS forms basically a standardized terminology, so that it can provide, radiologists can provide very clear, concise, and consistent reports. So there are reports from radiologists in Richmond. If patient moves to California and they transfer their imaging there, that radiologist and that patient can see the report and know exactly what the radiologist in Richmond was thinking, because it's a universal language overall. But with regards to usually the last line of the report, which is the assessment category, I can go through those as well here. Let me just pull up my handy dandy slideshow here and share screen. Okay, so at the bottom of the report, we have standardized terminology to list kind of what the bottom line is. And that can be helpful for patients and clinicians to know, there's all these things listed in this report. What does it mean? What do we do with this? So there's a numerical category assignment from 0 through 6. So we'll start at number 1. Number 1 is basically normal. You can go back to yearly screening whenever that is for you, but it's just nothing that really needs any specific follow-up. BIRADS 2 is there's something there, but it is not cancer. So it may be a cyst or a benign calcium deposit, or that thing that was biopsied 5 years ago that we still see. And this is something, again, that patients can just go back to routine follow-up. We're mentioning it, but that doesn't need any further evaluation. BIRADS 3 is kind of like what you mentioned, that category where we recommend a short-term follow-up, like 6 months. So something that is BIRADS 3 fits certain criteria that are well established in our literature. There's certain boxes that we have to check.
Right.
they have a less than 2% likelihood of being cancer. So to flip that, they are most likely not breast cancer with a 98% likelihood of being totally benign and not cancerous. But because we can't give you that 100% certainty as a
Right.
patient, we do recommend a short-term follow-up. And usually that is in 6 months, and then yearly with your annuals, 12 and 24 months for a total of 2 years. And then patients can go back to kind of routine evaluation. The BI-RADS 4 and 5, both of those are suspicious for breast cancer. The BI-RADS 4 is something that has a greater than 5% likelihood of being breast cancer, greater than 3%, I should say. And then highly suggestive is greater than 95%. Now, some practices further split these and stratify them into the A, the B, and the C. We don't typically do that here, but for both of these assessment categories, the recommendation is a clear-cut biopsy is needed. And that doesn't mean that, this is 100% cancer, but depending on the likelihood, it will fit, certain criteria. A biopsy is needed to sort it out. Some sort of sampling of the tissue, usually with imaging guidance, minimally invasive with a needle, to kind of answer that question. And then a BI-RADS 6 is for a patient that has a known cancer. So maybe they're on chemotherapy and we're just following the treatment response, but they know that they have a breast cancer. And then a BI-RADS 0 is a patient, usually we use this assessment for a screening mammogram. So if a patient needs to come back for more imaging to work up something that's potentially abnormal, or if the patient, if we need to get their prior mammograms to compare. There may have been a benign growth there their entire life, like since puberty, but we don't have their prior images. So before we work it up, before we do ultrasounds and biopsies, if they have a prior mammogram that we can access, we want the chance to look at that and look for stability before doing, anything unnecessary. So that is the BI-RADS assessment categories. Is there anything else that I can tell you about the report or how to decipher some of the terminology?
Oh my gosh, there's so many things on that report. We have to bring you back because there's even for ours, the tumors. Can you talk about that maybe a little bit? Because I know there's different sizes. Because I think I had one that was like 5. Was it 5 centimeters? I don't know, but it was just like, okay, I know something with the tumor sizes too sometimes. So can you kind of elaborate about that if you can?
Yeah, so some of the, I'm just going to unshare my screen again.
No, you're fine.
Okay, so the BI-RADS, remember, it was many things for quality assurance. And part of that systematic and uniform reporting applies to the description of findings. So for example, we have a specific glossary or lexicon of terms that we need to use to describe a lump. How many ways can you describe a lump? Well, the lexicon, the BI-RADS give us many, many permutations and ways. So we have to describe the shape. Is it round? Is it oval? Is it irregular? Describing the edges or the margins. Are they circumscribed, which means smooth? Are they spiculated, which means there's kind of little tentacles coming off of it, little whiskers or spicules. And each of those words means something. So the language is supposed to be very meaningful and reproducible. And so there's words that connote something more benign, like something that is oval, something smooth, that's kind of playing well with the rest of the tissue planes, versus something that is irregular, something that's bright and high in density and has these spicules or tentacles coming off of it. So those descriptors are associated with the likelihood of that finding being cancer on a biopsy, for example. And so there's specific descriptors that we have to use for lumps, for calcium deposits, for other findings, like something that we call architectural distortion, where it's not a mass and it's not a calcium deposit, but it's just a very disrupted area of tissue that can also be benign or the sign
Right.
of an early slow growing breast cancer. And then we're also required to tell where the finding is. Is it in the upper outer quadrant? If we're using ultrasound, we use a clock face to diagram where the finding is, and the size. And all of those things are relevant for management. If this is a breast cancer, we need to communicate that extent to the surgeon, to the oncologist, to be kind of clinically relevant so they can understand what we're dealing with, how much
Right.
is there, what are the treatment options. Jumping ahead, can this patient have a lumpectomy and partial breast irradiation, or is this patient going to need a mastectomy or neoadjuvant chemotherapy? So all of those things we put into our report to help guide the clinician. Even though we may still need to do a biopsy, that we want to give them as much information as we can to paint that picture about how severe or how small and isolated that disease is.
And so for the radiology, because radiologists work hand in hand also with the pathology, because after you do the biopsy, it goes to the pathologist, correct?
Yes.
Okay, so with that being said, so the pathologists, they come back to you to explain everything, and then, or do you, well, I know they have their own separate report, but how do you all kind of like work hand in hand? I heard how you work hand in hand with the breast surgeon. But yeah, I'm just interested with that piece, because I just remember getting the biopsy and then I got the pathology report, but then the radiologist was the one who called me initially and broke down the pathology report. So I was just curious about that whole scenario.
Absolutely, yeah. So part of that BI-RADS, which is a smaller part of the Mammography Quality Standards Act, which is under the FDA, requires breast imagers to follow back up, circle back with the pathology to make sure that it matches what we were expecting. So we call it radiology pathology concordance. So if we're expecting something that looks really scary on imaging, we say, oh my gosh, this is a BI-RADS 5, it is most likely a cancer. And our biopsy result on pathology is something benign, that doesn't match. And there's some mismatch that happened either in the sampling or maybe the patient had something that we didn't know about, that maybe the lump is a big mimicker that's faked us out. But the radiologist, the breast radiologist, does follow up on all the pathology from every biopsy that they perform, and interprets it in conjunction with the radiology to make sure that it fits the imaging findings. And then the radiologist, like in your case, will talk to the patient and go over the results. In some practices, it might be a nurse that does that, but in our practice, the radiologist calls the patient, goes over the results and the recommendations, and sets them up to see the surgeon or the oncologist if that is needed. We also document all of that concordance, and we're audited on that every year by the FDA to ensure that we are performing procedures appropriately, that we are following up on results and coordinating care for patients that need it, so that patients don't fall through the cracks, particularly if they have a positive diagnosis. But also for women that have good news, we want to make sure that they get back into routine screening for whenever that is, and they have that loop kind of closed, and then they can kind of move forward with their routine care.
I'm so glad you said that, because I remember the first report was benign. They were like, nothing's wrong. And I'm like, no. Something is definitely wrong, because they couldn't find anything, and they had done about 3 different areas. But can you let people know, like, I know when you do a pathology, it's only a little bit of tissue, so you could miss, potentially, not saying that y'all try and purposely miss, but you could miss like an area that's actually malignant. And so it's good to really advocate for yourself that if you know something's wrong, especially when we have symptoms, that maybe some more testing need to be done. And that is usually when you get into like the MRIs potentially, or no. I'm just
absolutely. So that's a great point, is that whatever we're sampling, we are just sampling it. We try to hit the highest yield area to get something that's really representative of what we think is going on, but we're using a needle in most cases. And even a large needle is only going to take a small piece of tissue, somewhere between a piece of linguine or angel hair pasta to the thickness of, maybe a fettuccine noodle, depending on the type of needle. But there is something called sampling error, and that's true for all biopsies of all organs, that you may not get representative of what is the actual crux of the lesion. And so that's something that we call as discordant. So that's a reason that the radiologist may raise their red flag and say, okay, this doesn't fit what I thought it was going to be. So they may talk to the pathologist and say, hey, have that conversation of, can you look at more of the sample, or, did you think it looked anything like XYZ? And in some cases, yes, if the things don't fit, we will recommend an MRI to sort of help problem solve. And in other cases, we may recommend repeating the biopsy with a different technique. So maybe if we did ultrasound before, we might use X-ray guidance, or I was taught you get one shot. And so if we don't get the right answer on the biopsy, or an answer that makes sense, for example, then we refer the patients to a surgeon to have that area removed, just the lump, so that the surgeon will get a bigger sample and more likely get the accurate representative diagnosis, rather than putting the patient through, a second or a third biopsy. Maybe just have the surgeon take it out and know for sure. The pathologist will look at it all under the microscope and be able to make a more accurate diagnosis.
Yeah. So you just answered so many of my questions for things that I went through, because when I was telling them, no, you need to try again, basically, they didn't do the one where you have the breast in the hole. What is it called? What is it called?
Stereotactic biopsy.
Yeah, tactical biopsy, because one area they were like, oh, it's probably a shadow. And then the other had the calcifications, and those two areas were not biopsied. And it was like, well, we'll watch it. And I'm like, no, this got to come out. And I was told, well, from this particular individual, oh, well, you don't want us to keep on cutting on you. And I'm like, you haven't been through this. You don't know what I'm dealing with. I'm hurting every day. And that's when they did bring me back in 2 months. They seen it had grown. And the one area was atypical hyperplasia. The other area was definitely DCIS. So that answered what you just said, answered a whole lot of questions, and I didn't know how hard I was advocating, but obviously I was going in the right direction. So
absolutely.
Yeah, I appreciate that, because after they did the pathology, after I did have to go and get my breast removed, they did see that had I possibly waited 6 months, it could have been a different story for sure, because of how much I was already at a grade 3. So
oh my gosh, yeah. And we try to advocate for patients too. Sometimes, even though something is benign, a lump is benign, we give the patients the option of, if it's bothering you, if it's painful, for example, some benign growths like fibroadenomas, especially depending on where they are, if you'd like to have it removed, we still can. We would still need to do a needle biopsy, because the surgery for a benign lump is different than a surgery for a cancer. But if the patient wants it out, and having a balanced discussion of the risks and benefits of surgery, the pros and cons for their individual situation, we're happy to refer them to a surgeon, at least for a consult, to have that discussion. And often the surgeon will also reassure them. Sometimes they'll go ahead and have the surgery. Sometimes just knowing that another breast specialist is following along with them, it makes them more apt to just want to continue to follow things and watch and wait. So again, just having that discussion and knowing that there are options. I can present options as the radiologist, but I can make a recommendation as to what I feel is the best path based on my experience. But I never want a patient to feel like they don't have any other options, because I'm not in their shoes. Even that probably benign, less than 2% likelihood of being breast cancer, if that 2% is going to keep a patient awake every night for 6 months, let's just go ahead and biopsy it and know for sure. And we can put it to rest and put it behind us. And everyone has a different threshold for their anxiety and their comfort. Someone had used the analogy that, if it's a 2% chance of rain, are you going to take an umbrella? And I would say yes, because, the times where it was not supposed to rain, out of nowhere. And so, I'm not in a patient's shoes. So whatever it's going on with their story, with where they are in life, if they are more comfortable advocating for a biopsy, then we advocate for them to do what makes them most comfortable.
Love that about you. Love it. Is there anything, because you have been so patient and so kind to come up here. So I want to respect your time,
Oh, thank you.
but hopefully you can come back again to get us
you.
caught up on some more stuff. But do you have anything that you want the patients to know that are listening, whether they have breast cancer or not? Anything that you want them to know, whether before they see a radiologist or whatever? I don't know, whatever, anything you want to share.
Just along the lines of what we've been talking about, just to ask questions and advocate. And if you don't know what to ask, then that's okay too. But we are a partnership. We are not, doctor-patient. We want to make sure that the patient is comfortable with the findings, with the plan, and they're an equal part in this,
Absolutely.
in this process. And so I encourage patients to ask questions, to ask to see your films. Sometimes patients will say, I don't want to bother you. I don't want to take your time. I specifically, we're in a teaching hospital. So this is what we do. We do that to residents and medical students. I kind of love when patients want to look at their images, because I get to, tell them, why I think this is not breast cancer, why I think this is breast cancer. And a picture is worth 1,000 words. Sometimes that can make all the difference for a patient to feel that connection and feel that confidence in somebody who is saying, oh, no, don't worry about it. It's most likely not cancer. Well, if you can tell me why and show me why, I will feel much more confident and reassured about waiting that 6 months to keep an eye on it.
Absolutely.
So that would be the advice that I have to patients.
Well, thank you. So I love that, because that was my whole thing. First of all, you're not feeling what I'm feeling, and something's wrong. Like, and explain it if I do need to wait or whatever, because I do try to work, because I feel we're a team.
Exactly.
But when you feel excluded from the team and it's your body, it can make you feel, annoyed. But at the same time, I do respect the professionals that work with me. So that's what I just love about you, is that you take the time to explain and you hear the patient, and you don't rush through that process. So I love that.
Well, thank you. And just along those lines, one quick thing is that another thing to sort of advocate for patients is, if they don't feel that connection, to get a second opinion. That we always
Absolutely.
that you want to make sure you mesh with the person that's taking care of you, your life in their hands. So everything has to fit together.
Absolutely. And with that being said, before we get into your song and your work, can you please tell everyone where they can find you, far as professionally, as far as working, where you're located and what you're connected to?
Yes, I'm going to share my screen again. I have just listed our websites, as well as a QR code for each. So this is the VCU Health breast imaging. When I tried it myself, it only took me to VCU Health. So you may have to search for breast imaging to find us. And then this is the website and a QR code for Massey Cancer Center. And that is the National Cancer Center that we're affiliated with. We just became a comprehensive cancer center, and we have that recognition, and it's a very special place to be here in Richmond, and very proud to be part of it. So just put in a plug for it. Not all mammograms, not all findings and lumps and things are breast cancer. I know a lot of people associate screening with cancer, but this information is just here since we work so closely with our oncologists.
I love it. Thank you so much. So now that everyone has the website, so vcuhealth.org services, well, it has the /services and another /breast imaging, breast-imaging, and then www.masseycancercenter.org. Make sure you go there, especially if you have a radiologist that may not be working well with you. Go get your second opinion there. I'm just throwing the plug out there. She's not.
Thank you.
Yes,
we're happy to take care of you. Absolutely.
Yes. So I appreciate that. So without further ado, before we wrap up, you chose a particular song. So I want you to just share the name of your song, the artist, and why you chose that song on your reel.
Okay. So I chose, I'm just going to unshare here. Okay. I chose Try Everything by Shakira. And I have to say, it's the song has been around a while, but I hadn't heard it until early summer, where it was performed very enthusiastically at a pre-K graduation of my daughters. And I did not understand the lyrics. 44 and 5-year-olds up on a stage in a high school auditorium singing and signing it, but it was very catchy and they were singing it, practicing it at home. So I looked it up and the lyrics just really resonated. And it's talking about falling down and getting back up again. One of the first lines is about, I lost another fight, but the fight was with myself. I think, as women, it's, not to stereotype us all, but a lot of us, overthink. Sometimes we're our own worst critics. All of us, men and women, we're all going through something, struggles, big struggles, little struggles, life-changing, life-altering struggles. And it's okay to complain and it's okay to vent. It's okay to cry and ask for help and to be stuck and fail and make mistakes. But at the end of the day, we all go to bed and wake up again and we do it all again. And we do that for ourselves. Oh, I'm tearing up a little bit. We do that for our families. Right. And so that song just resonated with me in terms of just giving it all you've got and knowing that falling down is part of that path moving forward. It's always forward progress, whatever we do, and to kind of look to your community, look to your friends, and look to your family to support you, to get you back up again, so that you can tackle those things again.
Absolutely.
Sorry, I got a little emotional.
It's okay. People get emotional. I get emotional. I usually am crying about something. So no, you're fine. So with that being said, your word, what's your one word that you could leave here with individuals who maybe they look at their scars every day, maybe they're mental or physical, and they look at them every day and they're just trying to get through, or they have wounds and they're trying to heal. What is your one word that you could leave with people and why?
It's kind of befitting the title of this podcast, of your podcast, storytelling. And that was just the one word that I could use to summarize, share your story, tell your story. Everybody, like I said, is going through something, but every patient is more than just their diagnosis. Here in breast imaging, I tend to see patients on sometimes the worst day of their life, or giving them kind of the worst news that they've heard. And I also, on the flip side, get to tell patients the best news. I get to give them, good news when they've beat the cancer, when they've come back as survivors. But that is just such a small part of their life, of their story. And talking to patients and hearing about them is just so amazing, getting to know them. I have a patient that survived a helicopter crash. I have a patient that travels the world as a missionary and comes back every 6 months for her mammograms and MRIs. Patients that, lived on Navajo reservations, or they taught kindergartners for 20 years. And so that diagnosis is just a small part of who they are. And it's not to minimize their journey, but it's to put that in perspective of their life story, and that, this journey will be woven into that thread of their story in the future, and to kind of keep that big picture that you are more than the diagnosis, and what you are will get you through this. That is what's going to get you through to survive, and share that story, inspire others, and give them strength and support so that they can continue forward as well, and inspire others to survive and to thrive.
I love it. I love it. So I'm going to share with you what I have to say about you. But before I do that, I think I will ask you to come back, because men, I know there's probably some different imaging. I don't know how men and imaging goes, probably about the same, but yeah, because I know some men are they have breast cancer too. So anyway, that's another story for another. Okay. But I wanted to share with you that you are significant. When I look at you, when I hear you talk, I think of hope. You give, regardless of what you give the patient as far as their diagnosis and what you find, you are significant in presenting hope, because you're the person who lets us know, okay, this is what it is. These are the things that just go back to talk to the doctor. You're significant. You're significant in the standpoint also that you're very unique with your demeanor and how you present yourself. You don't look down at the patient. You help build the patient up, even if you have to tell them something that's heart-wrenching. And I want you to understand that and know that about you. And I keep on talking about it, but it's so important because so many people, we're not sometimes given flowers when we're alive. People wait to give us flowers after we passed on. And I want you to have your flowers now, to know that what you're doing is such a significant part with not just the breast cancer part of it, but the patient-doctor relationship. And that has to go back to not just you going to school, realizing this is something passionate that you want to do, but your family. You were obviously raised by good people. This is a part of who you are, a part of your DNA. And for you to be here today to even share all aspects of what you shared is also showing that you're very generous of your time. And I thank you so much yet again for coming up here and for sharing, because yes, it is Our Scars Speak, but also we all have scars in life. We all have mental and physical scars that brought us to the place that we are now to be able to help the people that we help. So I'm sure in your life, you've had some bumps in the roads and you've had some challenges, but you're still here. You're a woman and you're still here in a profession that, like I always say, usually is predominantly men. And predominantly, I can say this, but predominantly Caucasian men. And you're here, a woman, and you're a woman of color, and you're here and that's representation. And I love the fact that Massey has representation of everybody, and some places don't, and that can make us feel uncomfortable. So thank you so much for giving of your gift and just giving of who you are as a person.
Thank you. I have no words. That was so extremely kind and thoughtful of you, because I just feel like I'm doing my job, being the doctor that I can be, and doing what I was trained to do. So thank you for taking the time to say those kind things, to hopefully inspire other patients and other providers. But that really
Absolutely.
a lot, especially having gone through your journey onto the other side. So thank you. And thank you for this platform for patients, for providers, for everyone, because our stories really can give others strength and hope. So thank you.
Absolutely. Absolutely. So without further ado, this is another episode of Our Scars Speak. And for each and every person who's listening, I want you all to know once again that your mental and your physical scars speak a story. When you're supposed to share that story, I do not know, but just know it's important and vital that you do so, because your story can help heal the wounds of another person. So with that being said, we love you, and I'll see you next week. Bye.
Thank you. Bye-bye.
Bye-bye.